future of women's healthcare in Ireland, where do we go next? And we'll be focusing on our aspirations, what we'd like to achieve. And as you can see from our panel and our lineup, we have a very diverse range of backgrounds here, from professional experience and lived experience. And we have, of course, our Minister for Health here, who's here to listen and to respond to the issues being raised. And we will have a Q&A session at the end of the panel as well. So I'll hand you over to Ciara Kelly, who's a former GP, Dr. Ciara Kelly, and now broadcaster and a very familiar voice on our radios every day. And Ciara is no stranger to asking the tough questions and is a strong advocate for women's healthcare as well. So Ciara, I'll hand over to you.
Can everybody hear, or you can indeed. Thank you all very much for sticking around for the day today. I think it's really a wonderful thing that is happening here. I'm old enough to remember when women's health was a sort of an also-ran in healthcare, and I think that has changed hugely, and that is a really good thing. To kick off, I'm going to introduce you to our panel. We have a really brilliant panel this afternoon. Dr. Lisa Cunningham is an emergency medicine consultant in Mayo and is also the team doctor for the Mayo GAA ladies and men. And you are also, which I think is really interesting, a pre-hospital consultant, so you fly around in helicopters and have a far more exciting career than I knew was available when I was a doctor, I have to say. Dr. Rhona Mahony, who will be very, very familiar to many of you, who is a consultant obstetrician and gynaecologist and former master of Holles Street. Thank you very much for coming today as well. We have Mary Brigid Collins, who is and I want to get your title exactly right, the Assistant Coordinator of the Pavee Point Traveller Primary Healthcare Project. And Mary Brigid has been very instrumental in highlighting the inequalities that traveller women in particular face in accessing healthcare and the biases that they deal with on an ongoing basis, and we'll be talking about all of that. And Dr. Nolan, who is from the ESRI, we're going to be talking about demographics, and we're going to be talking about research and whole life healthcare from children. You were involved in the Growing Up in Ireland study, I know, Anne, and thank you. And of course we're joined also by the Minister for Health, Stephen Donnelly. And Minister, I believe you're here in largely a listening capacity, and I will be no doubt asking you some questions, but I think it's very good and important that we have the Minister here today to hear the concerns of women and to hear the lived experience of women, but also the expertise of women on this panel. I think we might start with you, Lisa, largely because you're sitting beside me. When we talk about women's health, we often think of it as a niche, and we often think of it as maybe being something that would be under the bailiwick of Rhona. We think of reproductive health, we think of abortion, we think of maternity, gynaecology, those types of things. But women's health is obviously far broader than that. And to a large extent, the biggest killer would still be heart disease, and then maybe followed by cancer. We don't really think about heart disease as a women's health issue, but there are issues for women in accessing care for things like cardiology, things to do with maybe gender biases in medicine. Isn't that correct?
Absolutely, yeah. So I think, given my background as emergency medicine consultant, a lot of people would think, where would I have as much experience, in dealing with women's health? But actually, women's health issues is not just alone in relation to gynecology and obstetrics and reproductive health. So what I would see daily, on a daily basis, is that one of the largest killers of women is cardiovascular disease. And if I put it to you that a statistic that women are literally dying because of the gender bias, I think it's absolutely important for us to know. If I said to you about heart attacks, the first image I would guarantee that the majority of people will conjure up in their mind is a male clutching his chest, maybe a little poster that you've seen with it radiating down his left arm. But if I was to tell you that actually, women are misdiagnosed 7 times more likely to be misdiagnosed with a heart attack, because that is not the symptoms that they have. They present with a whole different range of symptoms. And that's actually labelled as atypical, which you'll probably remember. The woman is an atypical presentation of a heart attack. We're atypical because we're not typical compared to the man, which all the research would have been done for. So we know with men, when they have heart attacks, they have a certain pathophysiology that will happen with it. We also know that that pathophysiology will give them a typical symptoms of heart attack, chest pain, radiate to the left arm, etc., and the image that you've just conjured up. However, women have a different pathophysiology, but we have the atypical symptoms of potentially like abdo pain, clamminess, burping and belching. And this is a personal experience for me because my own mother-in-law was misdiagnosed of having a heart attack while I was standing beside her to another practitioner. And I just felt this, but I think she's having a heart attack. No, she has no chest pain, it's fine. To this day, my mother-in-law, this is 3 years ago, she will still maintain that she didn't have a heart attack because she didn't have chest pain. She had a touch of the heart, is what she said, even after having her treatment and 2 stents put in. And I think of that age group, that is your atypical presentation. Now, I'll take it one step further. If you get misdiagnosed as having a heart attack and you're in the emergency department, you get sent home with your indigestion tablets as a woman, and you're walking down the street and you have a cardiac arrest, which is where your heart will stop beating. Women are less likely to get CPR. So therefore, you're already shot in the foot when you've been misdiagnosed with a heart attack, and women are 3 times less likely to get CPR in a public place. And I think there's lots of different reasons for that, but one of them is also that people don't perceive women to have cardiac arrests. They'll say, well, maybe she's just unconscious, we put her into the recovery position, where we know that she needs an AED and she needs CPR. And I think it is important for women's health for reproductive, but this is something that I will encounter every single day, is the woman that comes into the emergency department and may get sent home because her symptoms of heart attack is not your typical one, which has been based on all the research over the last hundreds of years, which has been men. Now, we are changing very, very good with that. But I think even that language, somebody was saying earlier on about the language, even saying that women are typically atypical, but it's because we're comparing that sort of thing to men.
It's extraordinary what you just said, because you're talking about women being atypical. We're 51% of the population. No disrespect to you, Minister, but you're the atypical ones. Do you know what I mean? We're actually the majority, but yet we're always sort of put in as if we're almost like a minority interest group, and that's insane. One of the things you said, and it's funny because you've just reminded me of an occasion when I myself presented to A&E with a terrible headache, and I don't get headaches ever, I don't suffer with headaches, and I had a lumbar puncture 3 days beforehand, and actually what was happening, it was leaking from my back, there was a hole, and so I was in a bad way, and I went in, and I'm a doctor, and I was having neurological, not just symptoms, signs, right, there was definite signs, and a young male doctor asked me if I was anxious. And I really felt like killing him, to be honest, because I knew, no, I'm not anxious, there's something really wrong with me and you need to take me seriously. But I thought, if I, as a relatively assertive, middle-aged woman who was also a doctor and was able to describe very accurately what I was experiencing, was asked about how was my stress levels, I thought, what chance do other women have? And it's a very worrying thing.
And doesn't that go back to, you know, the beginning of medical culture is the hysterical woman and the stoic man. And we know that women are perceived as more behavioural, or as sometimes people will call it supratentorial, which doesn't exist. Supratentorial means that it's above your brain, which means it's outside your head that you're thinking about these things. Migraines and headaches in women coming into the emergency department are horrendously underdiagnosed. They are the opportunities for strokes, which again, when you think of stroke, you think of the fast, positive, somebody face, but there are a certain cohort of people that will suffer from a stroke in the back of their brain that do not present like that, and women have a more higher chance of that. And headaches is one of the things that they may present with. So we're horrendously misdiagnosed from the typical conditions that would have been already perceived from a male research perspective.
And before we move on from this, what can we do to address those gender biases? Because I remember being really shocked at how eager this, and actually a slightly more senior female doctor arrived into the ED, and she said, I'm just looking at your notes, you were here, you had a lumbar puncture, it's probably leaking, lie down. And it was all, and I was actually ended up admitted to hospital for about 5 days, whereas honestly the guy wanted to send me home and thought I was just, you know, a bit stressed, and I was really quite shocked because I wasn't expecting that, despite the things I'd heard. So what can we do to address that? I mean, we're talking about the future of healthcare for women. They deserve better, so what can we do?
Absolutely. So one thing that I've gotten from today is I cannot wait to go back to work and be like, right guys, listen, this is what we're going to do. Have an education sessions in relation to our medical practitioners who work in the likes of the ED, which is my specialty, to be able to tell them, when the women come in, this is the atypical presentations that they have, and I encourage them to know a little bit more. Dr. Avin said earlier on that she had 2 medical students that came around to her and they didn't know what hyperemesis gravidarum was. I said, if you were to ask them, did they know what erectile dysfunction was? I guarantee you they would. And I think one of the reasons for that is that the erectile dysfunction is probably more so in the public domain as well, versus the hyperemesis that we have. Maybe it's getting a little bit better now. So education for the medical professionals in relation to that, but also the public perception as well for that guy that you've all just thought about with the heart attack, actually having more posters of women and their little signs and symptoms that they have, to have it just even in that public domain. So education between the medical practitioners that we have that are forming the future, and also for our public domain.
Okay, so we need to have a conversation, and I guess that's what we're trying to do today. Rhona, you would be very much at the forefront of women's health as it is perceived to be women's health, reproductive medicine, obs and gynae, all of those kinds of things. From your point of view, the gaps in the system, when you look at the future going forward, and I think a huge amount has changed in women's expectations around what they want from their interaction with doctors, and I have to commend OBS, because when I was training as a doctor, I always felt OBS was one of the few specialties that really did value the voices of women, because not all did, let's be honest. And I think OBS was already getting it, that women needed and wanted a say in their own healthcare. But if you could perceive the gaps going forward, or the important things in your area specialty around women's health, what would they be?
Yeah, I mean, I think first of all, it's brilliant to be at this conference, and full credit to Senator Chambers, because I think if you read the strategy that she is putting out, we're actually hitting a lot of the big issues that are coming down the line for women. But and I think when you read it, you see the complexity of the issues we're dealing with, and the tendency for it to become really politicized. So it actually becomes really difficult to even have the conversations. Yeah. But the big area, I mean, menopause, it's brilliant to see menopause coming back, because so many women are living much longer than their reproductive years. We've tended to have this big focus on the reproductive years, and kind of menopause has been left out there. But this is the very time when women are suffering, the comorbidities that Lisa's describing, and actually the leading killer of women in pregnancy, leading cause of maternal mortality among them is cardiac disease. We're seeing that population getting older and having much more comorbidity, and then we're seeing women survive much longer into menopause. And we're not just talking about treating hot flushes. And one of the really frustrating things about women's health has been this kind of siloing of it. Yes. As a kind of, it's just an area of healthcare out there, it doesn't really matter, it's not really that important, there's much more exciting things to be dealing with. Actually, when you think about the role that women play in society, from growing up to bearing children, to rearing those children, often to being the carers, caring for parents, caring for others around them, and that kind of long life playing a really central, pivotal part in society. If you do not care for women, and if you do not address the issues facing them, then there's a whole intergenerational issue in terms of the care that's provided and women's ability to take part in society. I mean, one of the biggest examples, I think the most egregious law ever passed in this state, 1935, the Criminal Law Amendment Act, which banned contraception. I mean, you think of the impact that had on women who couldn't choose when to have their babies, who couldn't space their families, and were pretty much consigned to the home and couldn't work. Massive thing. We still have issues with childcare. We still have issues with the cost of childcare for women trying to get out into society. So there's all of the social issues that go with women, as well as the healthcare issues, and there's a real...
To the Minister very shortly.
Absolutely, and there's this real juxtaposition, and you can't consider one without the other, actually, because you've got to consider this in the holistic way. If you really care for people, it's not just about conjuring up treatments for this, that, and the other. It's about actually providing care, and that care means, nourishing women, supporting women, actually enabling women to get into society. So the big area is obviously menopause, fantastic, because we
are seeing persistent shortages in HRT, which only this week resulted in calls for a Minister for Women's Health. What do you think of that?
Yeah, this is really interesting. I'll tell you why. It's because there's been a sudden big demand for the HRT that's given transdermally. So that's either by patch or by gel, and that's because you avoid taking high doses of HRT going through the liver, breaking that down and getting your HRT. This is going directly into your system. You're giving lower dose, a better form of HRT. You need YAM is one of the base products for that, but you have to grow your YAM in advance. So for the last few years, we've had this massive increase in demand for this type of HRT, and then obviously with COVID, we had supply chains broken. But I think June, things are going to get a bit better, and that kind of access. We've had stockouts, so when you go to get your patches, your gel, I'm getting very interested in that now at my age, but when you go to get your gel, it has been quite difficult. There are alternatives there and kind of working around the system, but hopefully that supply chain will be addressed.
Do you think, though, the idea of a Minister for Women's Health, I know independent TD Rhona Murphy floated it this week, but Vicky Phelan, for example, has floated it before. Do you think it's a good idea or not?
I do, because of the interlink with the social issues, you know what I mean, and healthcare. There's just this tremendous link as you are looking at the cornerstone of society, how it rears the next generation, how it gives birth to the next generation, how it might choose not to give birth, how women choose their roles in society, allowing women to develop and grow according to what that potential is. And that's what healthcare has to be all about, is enabling women to get out there into society and to do all the things that they do. The big kind of clinical areas, I think, are menopause, urogynecology, the one thing I'm really passionate about is HPV vaccination, and all credit to Laura Brennan, and I often think of her and her family and the amazing work she did in turning around that whole story on HPV vaccination. We're now looking at a single dose vaccine coming up, and already we are seeing a reduction in the number of women in their 20s coming with advanced changes in cells around the cervix, and that's amazing.
The golden goose, isn't it? We have a prevention for cancer.
We have a prevention. I couldn't be more passionate about it. I really couldn't. And I think that's something. So we're having, all of these new things coming on stream, which we can really use to help. But it's about understanding that. But often they get politicized, and you have mixed messaging coming out, or you have messaging that's working against that, and that's not really helping anyone. I think the other big areas, obviously, that you might want to look at is the mesh. We've had big controversy in urogynecology, but at the same time, we have a whole cohort of women who are really suffering day to day with huge morbidity and who can't get to work and who can't do things because they have urinary incontinence. So we've got to find a solution to that. The mid-urethral string probably is a good solution and probably is a very reasonable thing to bring back, and we've really got to look at that seriously because the waiting lists are growing and the impact on women is enormous. I think mesh has gone for good, and that's a good thing. I think we all agree that's out, but I think some of the more minor procedures for urinary incontinence could well do with coming back in again. And cancer. We've 1,500 cases of cancer coming through every year. Endometrial cancer is probably the most common cancer, and that incidence is increasing. In line with increasing age and obesity and all the factors that encourage endometrial cancer. Ovarian cancer, though, might be more rare, but it is, unfortunately, has much poorer outcome. And up until recently, our outcomes in Ireland haven't been as good as other outcomes in Europe. So we are focusing, and a huge amount of work has been done already, but we need to really focus on that centralised care for the treatment of cancer, the expert MDTs, making sure there's a standardised approach to all of our cancers. We've seen the impact in units in the country. We saw in Letterkenny delayed diagnosis of endometrial cancer and the impact that can have on a disease that, when it's caught early enough, can be really treatable. So I think that's got to be, because of the potential impact, and because cancer kills women, that's got to be an area of real focus. And it's just really great to see the big four areas in Ireland now developing, that MDT developing, and the whole services that support that, the radiology, and all the cancer treatments and the drug treatments and the medical backup for that. But that really needs a centralised approach. In fact, many of the diseases need that kind of expertise, because when you think, even come back to menopause, a lot of that can be managed and is managed brilliantly in the community, but there will be complex cases that need to have that expert.
But even without complex cases, I think it's fair to say, and I am a former GP, that GPs missed the menopause for years, as well as the issue that it actually is. And I was talking to a friend of mine who'd be the same age as me very recently, and she was presenting with the thing that women do present with: am I going mad? Am I demented? I'm losing my memory, and all those things that you.
Absolutely.
It isn't just the hot flushes, as you said.
No.
And instead of her GP, who was a male GP, and that's just how it was, saying, oh, well, let's, maybe it's the menopause because you're 51 and you're having all these symptoms. He said, right, Jen, maybe we'll send you to the early onset dementia clinic. And there was nothing wrong with her other than but that's bad. That's very recent, and that's not good. And so we have an issue around the training of doctors, and maybe doctors' gaze being the male gaze as well, that we're missing big pieces of the picture of what women need.
I agree, and it's building up that experience, because when you think about it, it's not lack of sleep is one of the biggest things, and that has a massive impact on quality of life. I don't know if anyone here has experienced not being able to sleep, but there is pretty much nothing worse. And then you're trying to get up the next day, and you're just bit by bit, you're just finding yourself, it's just a nightmare. Scared to go to bed at night because you're not going to sleep. But and there's so many symptoms that are written off. The other thing can happen as well, as well as attributing all kinds of diseases to what is menopause. The opposite can happen, actually, and women are not listened to. And someone says, that's just the menopause, that's just another woman's thing.
Yeah.
We're not going to worry about that, when in fact there may be something much more serious going on underneath it. So, and again, it comes back, you're absolutely right, it comes back to that awareness, it comes back to the training that we have. It also comes back to our conversations, actually, because when we look at the approach to healthcare, I'm a great fan of the approach which is about that information out there, because women are in my experience, women are very smart. And when they have information, they're pretty good at telling, like your example, but many women are very good at expressing their symptoms, actually, and able to say, this is what's wrong with me, and understanding this. And with the benefit of that kind of knowledge, then I think they can also present in partnership with their doctor. So it's not this kind of, I'm the doctor, I'm telling you this. It's like you're sitting there going, this is the problem on the table here. these are the possibilities. How are we going to find a treatment path that actually
a collaborative approach,
but a treatment path that works for you, the individual, in your particular setting, because it's very easy to recommend all kinds of treatments that aren't available, maybe, and really simple treatment. And one example is physiotherapy after babies are born. If you're living in France, you have automatically got access to 4 free, physiotherapy sessions. That has a big impact on incontinence down the road. Really simple intervention. No real side effects. This is only good. And it also increases for the woman that awareness of how she can actually protect her pelvic floor, develop her pelvic floor. It's really empowering. And I know that's in the strategy here. And it's really impressive to see that level of detail. I mean, the one thing that I'm reading from the strategy that Deputy Chambers has produced is she's clearly talked to both women who are experiencing life as a woman and also to those people who are providing care for women. And you can see in all of the pillars, and I love the pillar on prevention as well, because so often in medicine we spend our time spending millions on treating the end stage of a disease,
and we could have
prevented so many of diseases are lifestyle related, and that's a good message, because we can actually do things that can make small things. It's not that we all have to live perfectly. No, and I mean, being human doesn't allow you to live perfectly. And
and
that's it.
But
we can
want that. But can I bring in Mary Brigid yourself? We just been talking about accessing healthcare and opportunities for women, and that health is important so that women can live full lives. So we need childcare, and we need prevention, and we need all those things. But traveller women face a much bigger hill to climb as compared to other women in terms of accessing this. What would make a difference to you and to the women that you work with and the women around you in terms of maybe being listened to by healthcare, but also being able to access services? Because we know that traveller health outcomes are much worse than the settled community.
It's true,
the longevity, all of those things. Like, it's a bit of an uphill struggle for you. So what do you need?
Yeah, I think it's a huge struggle, and always has been a huge struggle for lots of traveller women out there. And we know from the piece of research that we done in 2010, which we would see now, it's old information, but we know that traveller women, or travellers in general, face huge discrimination. And I know you're talking about the general population and that they're getting past the front door, but in some cases travellers don't even get past the front door, particularly for traveller women, because of the huge discrimination and the multiple forms of discrimination that travellers face within Irish society. But also you're talking about the general population that does live much longer than what travellers live. Life expectancy for travellers is only 64 years of age. Now that's both for men, and it's improved slightly for women, but it's gotten much worse for travelling men. And I know we're talking about women here today, and access and services is a real problem, and discrimination, but also the literacy is a huge thing as well for lots of women out there. And we've seen during COVID where you had an awful lot of services put online. We work with travellers out there that don't even have electricity, mightn't have the skills to use a phone, mightn't be able to go on the phone. So this isn't going to be another barrier in the future if lots of us has to go online to access services. And I know the group we had on before this, and they're saying go online, get this and get that, but that doesn't suit everybody. So you already have a group of people that's already facing huge health inequalities as it is, but if this online stuff comes in, we're going to be put much further. And I think it's about looking at lots of different women, not just within the general population, but you have lots of women from different ethnic groups that face huge different problems to the general population. And that's the thing that we're facing within the traveller community at the minute.
And Mary Brigid, what do you need then? Do you need advocates working with travellers groups, or do you need, what would, because I totally take on board what you're saying, and I believe you that there's discrimination and there's bias and there's a difficulty in accessing. So how do we change it? What do you need?
Well, what we need extra supports there. And now within the primary healthcare project, there's about 25 of them around the country, and we do work with women as well. We give information, and education is very important. Let it be about breast examination, smear test, healthy eating, young children around immunisation. That's all stuff that we do, because that's the woman within the household who actually kind of takes the lead in that kind of stuff as well. And we all know, like childcare and stuff like that. I think we need more and more women around decision making for women's health, and I think that's one thing. We don't need a group of men to kind of be sitting at the table. And if you look at politics and you look at women's role within politics, there's very, very few women within the Dáil that when they see them sitting down, there's very, very few women there. And I think the day is gone when you have a group of men sitting around the table making decisions for women. There needs to be women at the table. We're the people who knows what we're going through. We know what we experience, and we know what we experience of traveller women as well.
Yeah.
But we do know traveller women die much younger than the general population, and we do know that government departments are coming out and they're planning for people living longer into their 80s and 90s. But if you look at the different groups of people, they certainly wouldn't be planning for travellers, because life expectancy again is only quite young. Out of 40,000 travellers, we only got 8 travellers over the age of 85 years of age. That's shocking. Out of 40,000, that was any other community that would be uproar.
That is shocking.
Yes, it is, absolutely. And that's the thing that we've been pushing for the last number of years, is the Traveller Health Action Plan. And we have done lots of consultation with traveller groups and organisations around the whole country, and women as well has been involved as well.
So you have to think, I suppose, about the growth rate of the population, but then also the composition. And we all know that the population is getting older. So at the moment, we've got about 15% of the population over the age of 65. In 10 years' time, that's going to be about 20%. And that sort of pace of increase is increasing all the time. But I suppose one aspect that has really sort of come out of our research in terms of projecting what that means then in terms of the use of services, and then obviously for the public purse in terms of expenditure on those services, is that if you look between men and women, there's a really interesting pattern in terms of utilisation and substitution. What seems to be happening is that when men get sick, women are much more likely to enter long-term residential care when they get very sick or infirm, whereas men have a spouse at home generally to look after them. So there's that really interesting substitution, and we think that that is obviously going to be a major sort of policy issue going forward. So I think people have spoke a little about sort of the caring responsibilities. Another thing I think that's interesting as well, and I think Rhona mentioned this as well in terms of the labour market, is you see this phenomenon as well of the sandwich generation. So this is where women, they have potentially, teenage children, but they also have living parents as well. And they're sandwiched between the two, and they're also trying to work. And that's a phenomenon that you see sort of coming through in the Irish context at the moment, just by virtue, I suppose, of the fact that, we have increasing longevity, so our parents are... I suppose in terms of the sort of only here, so you'll see that actually our projections show that we expect that actually there'll be a reduction in demand for maternity services, for the next 10 years or so. The expenditure won't decrease by as much, and I think that's possibly due to the sort of increasing complexity of cases and sort of risk factors for sort of more expensive deliveries. But that's really a sort of a focus and a sort of a consequence of the fact that we had really strong sort of population growth in the 70s and 80s. So my generation, part of the sort of baby boom, we then had children, in the sort of early part of the 21st century, but that's really starting to fall off. So you'll see that sort of reflected in projections then around maternity care. So I think there's sort of interesting dynamics in terms of the use and also the expenditure on different types of health services as you go through these sort of demographic projections. Just, I suppose, as a final note in terms of demographic projections, they're really difficult to do, and we've often been wrong. It's reasonably okay in terms of projecting births and deaths. We can do a reasonably good job of that. But in Ireland, what really determines sort of the ebbs and flows in terms of the population is migration. And I know, Mary Brigid, you mentioned sort of ethnic identifiers and ethnic inequalities more generally. But really one thing that determines our sort of size of our population and the growth of our population is these sort of net migration flows. And I think an earlier panellist mentioned, 17% of the population were not born in Ireland. And that obviously leads to, particular issues in terms of sort of access to healthcare. Mary Brigid mentioned it in the context of travellers and sort of navigating a health system that, might not be sort of, designed for your particular needs. And we've also shown this at the ESRI. There's some evidence in relation to, for example, use of healthcare services like GPs and consultants among people who are not born in Ireland, that even when you take into account, you know, insurance or their health status, they still have lower levels of use of healthcare. So, you know, there's something else going on there, and it's obviously, you know, potentially due to sort of difficulties in communication in navigating a health system that they're not familiar with. So I'll leave it there in terms of the broad patterns.
You know, reduced life expectancy, you know, I mean, this mortality, whether we're looking at morbidity, whether we're looking at outcomes, we saw this in COVID. Time and time again, we see actual harm, morbidity, mortality arising within ethnic groups, and I think that is a real key area across the system, and not just for women, but for men too, actually, but across the system that we do need to engage with.
I would like to get some reaction from the Minister. Minister, what I'm hearing from all the women on the panel here this afternoon is two things. One is, it seems to me that there is an expectation, and women are being sort of groomed societally to be society's carers, and who cares for the carers, but also that there are significant barriers for women in particular, and that is an exaggerated version of that for women from a minority group, accessing healthcare in the first place. So we have twofold. We have like the little red hens of society running around, not being listened to, not being looked after, and significant real barriers that are resulting in adverse outcomes for women in accessing healthcare. What are you going to do about it?
It's been clear to me women with the healthcare they need. I've seen it in my own family. I've seen it with my female friends. You know, I over many years had conversations with female friends of mine who were presenting a bit like your story, Ciara. You know, they were presenting sometimes, let's say, with a serious hip issue, and we're just told, well, you know, that'll be due to the child you gave birth to 3 years ago, and you know, don't be worrying your head about this. This very patriarchal, very patronising culture, but also services that aren't designed around women, services that have been designed around the healthcare system and around the state. And as we know, it has always been a patriarchal state, right? And so I was determined to be part of changing that, right? So what I said when I was appointed to office a little under 2 years ago was that in terms of clinical strategies, we have many excellent clinical strategies. The problem is they weren't being funded. So I said, okay, we're going to fund them. We're going to fund the cancer strategy, the maternity, dementia, trauma, etc. We're going to fund all of those, but we're missing a women's health strategy. And so the conversation we had politically, the conversation we had in government, the conversation I had in the department was, I'm not interested in a 5 or 10, I'm not interested in a sort of a 3-year intellectual exercise as to how things might get better in the future. I want an action plan, and it must be radical, right? We're not looking for things to get a little bit better each year for the next 20 years. We need radical change, we need radical improvements. And we need it in 2 areas, and they've been covered really well here today. In services, we need services designed around women. We need radical improvements in them. But we also need to change the experience of healthcare. So before I ran for the Dáil, I was working in the NHS and working around cultures within healthcare systems. And a lot of it there were a lot of issues being raised in the NHS at the time. And so what we did was we had this incredible group, the Women's Health Task Force. They spent about a year listening. They went all around the country, listened to clinicians, service users, advocacy groups, and what they brought back made for very sobering hearing. It was page after page after page of the doctor who hasn't got the training. So there was a huge piece of work was done there, and there's a really strong team within the department and the HSE, and they've had the great benefit of being able to reach out to many of the people, you know, the kinds of people who've been speaking here today. So the second thing then we needed to do was find the money. So to give you a sense of where we're going in terms of the funding, in 2020 there was €4 million ring-fenced for women's health. Now, there was more money, obviously, there were other things going on, but there was €4 million. This year it'll be €40 million, right? So we'll have gone up by a factor of 10, and the full year amount for this year's services is actually €50 million. So we'll have gone from 4 million to 50 million in a year and a half, right? Because without the money, it's just talk, right? As anyone working in healthcare or using the system, without the cash, It's all just good intentions, right? So what we're doing is we're saying, what we need is we're building out a national network of service provision. And at the same as the GP lead for primary care, we're investing. Now, 12 months ago we had none, right? So we'll have a national network of 20. They're incredible, right? So the one in the Rotunda, which I was in about 6 months ago, in its first 3 months of operation, reduced its long waiter list by 90%, 90%. The one in Galway was beginning to see similar results. There's one in the NMH, we have 20 of them. So 8, we opened 8 last year, we're opening the other 12 this year. We're opening 6 regional fertility hubs. We've specialist menopause clinics, specialist endometriosis clinics, eating disorder teams. And what we've been working on is designing all of this around women and life stages, because for men it's more linear. You know, there's this massive turn at puberty, and then it kind of steadily gets better and steadily gets worse, and then something bad happens to you broadly. It's not that, but of course it's